So Dr. Meg Dillon is an audiologist and a PhD, and she did her training at the University of North Carolina. And today she's going to talk to us about imaging and the management of CI users. So thank you very much, and congratulations on your recent diploma, as you were just telling us.
Thank you. I'm thrilled to be here. Thank you so much to the House team and Dr. Bigelow for the invitation to come and present and share some of the things that we've been working on. I thought that this would be a fun topic considering overlapping interests between our two groups and could potentially stir a good discussion. So first, my disclosures: I am supported by a research grant from MED-EL Corporation, as well as an R21 grant from the National Institute on Deafness and Other Communication Disorders. So first, I'd like to acknowledge our team at the University of North Carolina. The work that I will be sharing, you will see not one person can do alone. It does take a village. And I'm very fortunate to be able to work with this group of people, of researchers, audiologists, physicians, speech language pathologists that are all dedicated to advancing evidence-based practice. So what I'll talk about today is the use of imaging in the management of cochlear implant recipients. So once they get the implant, not necessarily what's happening during the candidacy and referral process. So first, I'll talk about the traditional use of intraoperative and postoperative imaging, and then spend the bulk of the talk talking about current studies on individualized mapping, specifically looking at electric frequency to place mismatch and how this might influence the monaural speech recognition of EAS users, or electric-acoustic stimulation users, as well as the binaural hearing of cochlear implant and EAS users with unilateral hearing loss or single-side deafness. And then I'll briefly end with future directions of what our team is thinking about when it comes to imaging. So first, the traditional use of imaging. At the University of North Carolina, it's standard of care for all of our patients, pediatric and adult, to have an intraoperative X-ray after the placement of the cochlear implant. And then in our adult population, we are obtaining a postoperative CT scan at the initial medical follow-up. And typically that's anywhere from 1 week to 4 weeks postoperative. And we know that we can use imaging either intraoperatively or postoperatively to consider to assess the device placement. So in that, thinking about that, we're thinking about the electrode array misplacement. So are we in the cochlea or are we somewhere else? Extracochlear electrode contacts, as well as tip fold over. So reasons that you might want to revise the device or move to a different device while you're still within the case. And then postoperatively, if we can see some of these things, such as an extracochlear contact, then the audiologist can make that decision to deactivate it instead of the patient having stimulation from that contact that could not be beneficial and could, in some cases, either cause some facial stimulation or, in some cases, pain for the patient. So we want to make sure that we avoid that. And I included some images here. So this is pretty dark on my screen, but this is an intraoperative X-ray. And so we can see that in this case, this red dot is indicating the round window. And so we have a number of contacts that are extracochlear. And so the physician would communicate with the audiologist that they're extracochlear, and we would deactivate those. There are two images here, one of basal buckling, and then one of tip fold over. And so in this case, if this was not revised, and so if this was not taken out and either a new device put in or repositioned, this would need to be communicated with the audiologist so that we're not providing stimulation of all of these contacts, because this is not going to be beneficial for the patient, and we're really going to spend a lot of time talking about why that's important. And to take a step back, when we think about signal coding for cochlear implants, when the speech information is coming in, this is a very general overview, we're dividing that frequency information up, and we are distributing that to each of the active electrode contacts. So in this particular case, if all of these contacts remain active, we're now providing all of this frequency information to the same cochlear place, and that could be detrimental for speech recognition. So if this electrode remained within the cochlea, we would want to deactivate some of these contacts so that we are providing the patient with better spectral representation and ultimately better speech recognition. And then in this case, we have an electrode array in the vestibule, which is not a great place to be shooting electric stimulation unintentionally. This was a case that we encountered recently, and so this was a transfer patient. And so this is speaking to the importance of obtaining imaging when we see that there is poorer than expected performance in a patient. So this child transferred to our clinic. He was a bilateral cochlear implant recipient, and it was noted by the pediatric audiologist that speech discrimination was poor in one ear. In fact, he had no detection of sound in one ear relative to the other ear. And we obtained a postoperative CT, and we can see here that the implant is entering into that basal turn, but then ultimately it's ended up in the internal auditory canal and is coiled within the internal auditory canal. And from this view, we can't really tell if it's coiled around the nerve or if it's seated on top of the nerve. And we sent these images to our friends and colleagues at Western University, so Luke Helpert and Sumit Agrawal and Ladakh. And they provided us with these images, which are just super fun to consider and thinking about the future of what we can use imaging for in the management of cochlear implant patients. And so here we can see our cochlea. Again, here comes this lead in orange where it's entering into that basal turn, and then it's exiting and coming into the internal auditory canal and coiled within the internal auditory canal. And then we have a different view of it here where they have recreated the internal auditory canal so that we can see that likely it's seated on top of the nerve as opposed to wrapped around the nerve. And we use that imaging information to make some mapping decisions for this particular patient that we've just recently published. All right, so what are we doing currently? So right now we are, our main research question that plagues all of us in cochlear implant research is to identify the variables that are contributing to the performance variability in our cochlear implant and EAS users. And this is a very famous plot from Jill First that depicts this. And what she has taken is cochlear implant users of all three manufacturers, Cochlear, AB, and MED-EL, and ranked them from the poorest performer up to the best performer on CNC words. And what's interesting about that is we see this wide range in speech recognition that was not driven by one manufacturer. So we saw this variability across all three manufacturers. And then here on the right, I have plotted some data from our center from the EAS clinical trial that we conducted that Oliver Jinka published in 2013 of their CNC word scores from the poorest performer up to the best performer in our clinical trial. And same thing that we're seeing here is that there's wide variability in speech recognition performance for EAS users as well. And we know that there are variables that contribute to this performance variability across CI alone and EAS users. Age at implantation, so typically our older adults tend to have poor performance than our younger adults. Duration of hearing loss, and so if you have a long-standing severe to profound hearing loss, your outcomes with a cochlear implant or with EAS may be poorer than somebody with a short duration of hearing loss. The electrode array placement, so Charlie Finley had a very famous paper looking to see where these electrodes were within the cochlea and seeing that if you pop into the scala vestibuli, that those outcomes are not necessarily as great as if you stay within the scala tympani. Electrode array design, and what I'm talking about specifically here is the length of the electrode array. So our center, the Buckman et al. 2014 study, did a randomization of patients with bilateral severe profound hearing loss, and they received either a long array or a shorter array. And we saw that those recipients of the longer array tended to do better faster than the recipients of the shorter electrode array. Low frequency acoustic hearing. So for EAS users, the more low frequency acoustic hearing you have, the better the outcomes with EAS. And then duration of device use. So we know that there is this ramp up period that we typically see in cochlear implant recipients where performance is specifically speech recognition is increasing with the duration of device use, and then eventually we hit a plateau. But we think that the variability in angular insertion depth, so specifically how deep we are with the electrode array, could also be influencing this performance variability that we're seeing in CI alone and EAS users. And so here's a depiction of the variability in angular insertion depth that we have seen in our patient population. So here we have recipients of the Flex 24, which is a 24 millimeter length electrode array, a lateral wall electrode array, a 28 millimeter array, and then 31.5 length of electrode array. And on this axis, we have the angular insertion depth of the most apical contact. So our deeper insertions are up to around 720 degrees for this patient population. And then on this axis, we have the predicted spiral ganglion frequency for that given angular insertion depth. So the first thing that we see, which is not surprising, is that the recipients of the 24 millimeter electrode array tend to have a shallower insertion depth than the recipients of the 31.5 millimeter array. And that makes sense because this one is longer than the 24. Importantly to point out is that all of these recipients have a full insertion of the device. What we were not expecting, and what is particularly compelling as we think about how we might want to apply this mapping wise, is this wide variability within recipients of the same electrode array. And if we look specifically at the 28 millimeter array, we can see our most apical contact could be stimulating a cochlear place frequency of around 750 hertz, all the way down to around 125 hertz. And the thing to keep in mind is currently on the audiology side, we are not considering this variability when we are programming the cochlear implant. And that could be contributing to some of this performance variability. Ooh, this is a sensitive thing. All right, so let's take a step to the side and think about the way that we are currently mapping, or the default mapping procedures for cochlear implant alone and EAS devices. So again, we are not incorporating the specifics of where an individual's electrode array is within their cochlea in regards to cochlear place frequency. So what we are doing currently is a patient will come in, we will apply the default filters. And so here's an example of 70 to 8,500 hertz. The goal of signal coding is to improve speech recognition. And so this is that speech recognition or speech spectrum range for this particular device. But what this can result in by not incorporating where we are within the cochlea when we are programming the filter frequency assignments is what's known as a frequency to place mismatch. And that is the discrepancy between the frequency information that we are providing with a given contact and that cochlear place frequency. And this is a cartoon of what could be happening here. So we have our cochlear implant, and then we have our angular insertion depth for different points within the cochlea. And if you know angular insertion depth, you can plug that in to a frequency to place function and get your cochlear place frequency. And so in this case, we've taken angular insertion depth and plugged it into Stokowskaya's spiral ganglion frequency to place function. And so now we have the cochlear place frequency for these different points within the cochlea. But again, I'm not considering this when I'm programming the device. So I will apply 70 to 8,500 hertz. And for this most apical contact, the center frequency for that filter will be 120. And now we see this discrepancy between the frequency information that I'm presenting for this contact and the cochlear place frequency. So I'm presenting 120 hertz to a place of approximately 525 hertz. And so there's this mismatch in the frequency information and the cochlear place frequency. For EAS, we do incorporate more information about the individual when we are programming, and that is the unaided acoustic hearing is helping us drive the decision making. So with EAS, because we have the combination of acoustic and electric stimulation, the current default mapping procedure is to divide that information between the acoustic and electric components, so that you are providing the listener with the full speech spectrum, that we don't have any gaps in what we are presenting, and to avoid too much overlap between the two stimulation modes. So the way that we do this right now is we look at the patient's unaided hearing thresholds, and we look to see where is the region of functional acoustic hearing. And for some devices, that rule is 65 dBHL. For others, it's 70. In this case, we are using 65 dBHL. And so we identify that region of functional acoustic hearing. And so that frequency information will be distributed and presented by the acoustic component. And then we assign this frequency, so that highest frequency of functional acoustic hearing, as the low frequency filter for electric stimulation. And we logarithmically distribute the remaining frequency information along those active contacts that are within the cochlea. And the benefit of this is we are providing the listener with that full speech spectrum. So the combination of acoustic and electric stimulation without any gaps in frequency information. The limitation is that we're still not accounting for where we are with the electrode array, and that could be important for this patient population. So again, this is what this looks like. So we have our cochlea and we have our implant that is placed, and we have our spiral ganglion place frequencies along that cochlea. And in this case, we'll first pay attention to the acoustic hearing. We identify that region of functional acoustic hearing, and that's going to be represented acoustically. And then we take that highest frequency of functional acoustic hearing and define that as a low frequency filter for the electric stimulation. But what that results in here is we're going to put 313 hertz at a cochlear place frequency of 525 hertz. So again, we have this mismatch in frequency information. More recently, we have seen that some patients can actually have hearing preservation with longer electrode arrays. And we have seen cases where we have electrode contacts that are within the region of functional acoustic hearing. And so in this particular case, again, I'm not considering that when I'm programming these filter frequencies. And so now I'm delivering a center frequency of 313 hertz to a cochlear place frequency of about 81 hertz. And so now I have an apical shift in frequency information relative to the cochlear place frequency. Another issue that I could be having here is what's known as electric on acoustic masking or peripheral masking. Because if I'm not considering that these contacts are within that region of functional acoustic hearing and I'm providing electric stimulation, it could be that the electric stimulation of these contacts and even some of these more basal contacts relative to the region of functional acoustic hearing could be masking the potential benefits of that low frequency acoustic hearing. So again, we think that it's important to consider where we are in the cochlea when we are making these decisions. Now, you're probably thinking, does it matter, these electric frequency to place mismatches that we have? So for CI users in simulation studies and in patients listening with CI devices, it has been shown repeatedly that there are negative effects on vowel recognition, word recognition, and sentence recognition. And we can see a depiction of that here. So on this axis, we have absolute frequency to place mismatch in semitones. And so what that means is we've taken those that have apical shifts and basal shifts, taken the absolute values so that we can look at the correlation between frequency to place mismatch and performance, instead of looking at this bell-shaped curve that could happen with the two different modes of shifting. And then we have our CNC word score on this axis. And what we can see is this relationship between frequency to place mismatch, and this is at the 1500 hertz cochlear place frequency, because we know that mid-frequency information is very important for speech understanding and performance, where listeners that have more mismatch or greater magnitudes of mismatch tend to have poor performance than listeners with less mismatch. And that relationship is staying at the 3-month and the 6-month mark. Now, arguably, we are looking at patients, that, a limited amount of patients here that have, about an octave of mismatch in this patient population. But this has been shown in other patient populations too. It has also been shown that CI users and in simulation studies that listeners can acclimate to electric mismatches, and in some cases can acclimate pretty quickly, sometimes in a matter of hours of auditory training. So it could be that you have these mismatches, but the brain adapts pretty quickly to them, either within a couple of hours, sometimes in a couple of months. Though it has been shown in some patient populations that this does not always happen completely and could take a very long time to occur. For EAS users, we don't know as much as we know in cochlear implant users. Right now, it's just limited to simulation studies. And these are data from our center on a masked sentence recognition task from normal hearing listeners of CI alone simulations as well as EAS simulations. And I'll draw your attention to the performance of the the EAS simulation outcomes. And this is on a task of the AZ biosentences. And these are the data from the 10 dB SNR. And this is in that 10 talker masker. So what we are using clinically with the minimum speech test battery, the AZ biosentences and a 10 talker masker at 10 dB SNR. And what we can see for the listeners that were assigned to the EAS default condition, and in this range, it was 250 to 8,500 hertz, so very limited acoustic low frequency information at that 125 and 250 region is what was being represented acoustically. And so we can see that their performance is about 40% correct on this sentence recognition task. However, our listeners of a place-based map, again, simulation study, we're getting about 60% correct on average. And this was without any auditory training, so that's important to point out. The other thing to note is that there was this minimal gap between what was being represented acoustically and what was being represented electrically, between 250 and 550 hertz. And that's exciting because previous studies had shown us that if there was a gap between the acoustically represented information and electrically represented information, that was detrimental for speech recognition performance. However, it's been shown by members of the House team, as well as others, that if you have a gap between those two modes of stimulation, that listeners are tolerant of it if you're aligning the electric information to cochlear place. So if we are following the cochlear tonotypicity, then listeners can tolerate a gap in speech information if it's provided correctly by the acoustic and the electric components. And that's really interesting and compelling for our area of the field. We think that this is particularly important to consider because approximately 60% of our EAS users have electric mismatches. So this could be influencing the majority of our EAS user population. The other thing to keep in mind is the influence of mismatches on binaural hearing. So previously we've been talking about monaural perception, but what does that mean for our binaural hearing abilities? Because if we have mismatched information in one ear relative to the other, that's creating an interaural mismatch. And that could negatively impact your ability to use binaural hearing cues. And that has been shown in bilateral CI users, where we have electrodes that are either two different types of electrodes, or as we saw earlier, you could have the same electrode, but because of your cochlear morphology, they're just in different places. But having interaural mismatches results in poor lateralization, poor binaural fusion, as well as poor discrimination of interaural timing and level difference cues. So it could be that these patients are limited because of these mismatches in information between the two ears. And this is alarming because we should think about our patient population that is growing right now with these recent approvals of the indications of cochlear implantation for single-sided deafness or unilateral hearing loss. So we now have all of these CI users that have normal to near normal hearing in the contralateral ear. And if we are presenting mismatched information with the implant relative to the normal hearing ear, that could also result in interaural mismatches between the frequency information. And I use the term unilateral hearing loss more than single-side deafness because in our patient population in the clinical trial that we ran, we were looking for patients that have moderate to profound hearing loss in one ear. So that's not truly single-sided deafness. So there were some, as we see here, that had pretty decent acoustic low frequency hearing and looked more like a traditional cochlear implant candidate in one ear as opposed to just a profound hearing loss. Now, we haven't applied some of these or we haven't applied where we are in the cochlea to our mapping procedures, at least clinically, because we haven't had the ability to know where we are outside of guessing. So if we knew the length of the electrode array, we could guess, approximate where we were in the cochlea. However, now we have tools to use imaging to more accurately estimate where we are with each of those contacts within the cochlea relative to the cochlear place frequency. And this is an image from a publication of a MATLAB script that was written for intraoperative x-rays. And so we can see that when we're in cochlear view, we can use this script to determine the shape and then identify each of those contacts, which once you have angular insertion depth, you can plug that into a frequency to place function to know your cochlear place frequency or estimate your cochlear place frequency. We also have other tools using our postoperative CT images. And this image is coming from a publication looking at Otoplan specifically, where we can identify a couple of different views and then use that to identify where our contacts are and calculate angular insertion depth. So we now have tools that help us more quickly and more accurately know where we are within the cochlea and could apply that to our clinical mapping procedures. And we have been doing this at our center with a procedure that we've been referring to as place-based mapping. And the point is to individualize the electric filter frequencies for each patient. So we take the postoperative CT scan, we calculate the angular insertion depth for each of the contacts, estimate the cochlear place frequency, and then we adjust the individual frequency filter assignments for each channel so that the frequency information matches the cochlear place frequency. And we are doing this up to 3,000 hertz and then up to at least 3,000 hertz. And then we'll logarithmically distribute the remaining high frequency information for those more basal contacts. And this is eliminating electric frequency to place mismatches in that low and mid frequency region, which we think could be very important for speech recognition. So let's look at some of our preliminary data that we've been collecting. So the data that I have for you today is from this prospective repeated measures clinical trial that we have been conducting since 2019. 2020 hit us, and I thought that was going to hurt for us for a little bit, but thankfully we've been able to continue cochlear implant procedures, and patients are continuing to want to participate in some of these research studies so that we can monitor performance over time. For this particular study, we are following CI and EAS users over the first year of listening experience, and they are randomized to listen exclusively to a default map or a place-based map. And we are looking at the influence of electric frequency to place mismatches on the growth in speech recognition and spatial hearing abilities, as well as the patterns of acclimatization across patient populations. The data that I have is from two subsets. The first is from our EAS users and just looking at their monaural speech recognition, because we think that the influence of these electric mismatches may be different for EAS users than it is for CI alone users. So as a reminder, we have seen previously that CI alone users and normal hearing listeners in CI simulation studies, that they are able to acclimate quickly to minimal electric mismatches, and then with auditory training can acclimate to some larger mismatches, in some cases not completely. But this might be different for our EAS users because they have that acoustic hearing in the implanted ear. So it could be that because we have that acoustic normal to moderate low frequency hearing, that is making it more challenging for the listener to acclimate to shifts in electric stimulation, and that when you align that information to cochlear place, that's why they're showing these greater benefits and are more tolerant of some gaps in frequency information. For binaural hearing, the data that we have are from CI and EAS users with normal to near normal hearing in the contralateral ear, so our unilateral hearing loss or SSD users. And this is based on the hypothesis that binaural hearing abilities may be better when we have minimal intraoral mismatches between the electric and acoustic stimulation. So first, let's look at our EAS users on this monaural hearing task. So again, they're randomized at initial activation to receive either the default or the place-based map, and they're listening to that exclusively over the study period. For the default map, we are applying the clinical software recommendations for the electric component. So first, we program the acoustic component, and we are verifying that to NAL and L1 targets. And then we program the electric filter frequencies, which again are based off of the unaided hearing detection thresholds. For the place-based map, we are programming the acoustic component the same way, verifying to NAL and L1 targets. But for the electric filter frequencies, that is where we are looking at the post-op CT scan, calculating the angular insertion depth for each of those electrode contacts, estimating the spiral ganglion frequency, and then aligning the low and mid frequency information to match the cochlear place frequency. So we have two tasks that they are completing in this monaural listening condition. The first one is a vowel recognition task using the Tiger Speech technology English vowel recognition task. And for this, the participant is connected or listening direct connect to the computer, and they are hearing these different stimuli, and then they select which one they think they heard. So each of these stimuli differ by that internal vowel. And the data are scored, or the responses are scored as a % correct for vowel recognition. And this is obtained at initial activation and then the 1, 3, and 6 month post-activation intervals. We're also doing the CNC word task, and that is administered in the sound booth, presented in the sound field with the contralateral ear mast. And this is presented at 60 dB SPL and scored in % correct. So the same task that we would do clinically for our cochlear implant users and EAS users. And again, data are collected at initial activation, the 1, 3, and the 6 month mark. And for the initial activation interval, we really wanted to see how quickly are patients acclimating, or how much are they being impacted by a spectral mismatch or a frequency to place mismatch. And so they see the clinical team for the initial activation. The clinical team is aware of the assignment of default or place-based. And then they come down the hall and see a member of the research team, and the research audiologist that is conducting the assessments is blinded to whether the participant is in a default or a place-based map. And this is about 20 minutes after activation. So really green when it comes to sound of electric stimulation. So we currently have 21 adult CI recipients with functional acoustic hearing, which we're defining as 65 dB or less in the implanted ear. Our age at implantation ranges from 22 to 78 years, with a median of 66 years. And then we have recipients of the 24 millimeter arrays. We have 11 of those, 6 of the 28 millimeter array, and then 4 of the 31.5 millimeter array. And so thinking about that, that introduces a wide variability in our angular insertion depth. So we're anywhere from 370 to 691 degrees. And that puts us at a cochlear place frequency of 809 to 118 hertz. And these are those early data. So we have our vowel recognition scores on the left, our CNC word recognition scores on the right, and this is in % correct. And then we have the data from the activation interval, the 1 month interval, and then the 6 month interval. And I cut out the 3 month interval just for ease of viewing. So what we can see here is that it's pretty mean to assess CNC words at initial activation. We can see all of our participants are at floor. And then we also have the results from the vowel recognition task here. Importantly, the listeners that are in the open symbols are the ones that have been randomized to a place-based map. The listeners that are in the filled symbols are the ones that are randomized to the default map. On this axis, we have, again, absolute electric frequency to place mismatch at 1500 hertz. And so 0 indicates a match between our center frequency and our cochlear place frequency for the contact that is around 1500 hertz. And then we can see as we get further and further away, greater magnitudes of electric mismatch with 12 semitones equaling an octave of electric mismatch. So we're not seeing an effect of electric frequency to place mismatches at these early intervals. But what we start to see is that those with minimal amounts of electric mismatch are jumping up in speech recognition early and staying with superior performance, while our listeners of default maps have greater variability in their speech recognition abilities. And we start to see this shape develop around the 6-month mark, where we see that those with minimal amounts of electric mismatch are doing better than those with larger magnitudes of mismatch. And that's a little bit more pronounced with our CNC scores here. We can see that those with minimal amounts of mismatch, even those randomized to a default map. So again, sometimes with a default map, we can get close to the cochlear place frequency. But as we get further away, we tend to see this poorer performance. And another way to view this, which was actually Dr. Manita Chatterjee's recommendation to plot these data, and for those of you who know her, know she's brilliant and genius and just so fun to work with. But she recommended that we plotted these data in a different way, where we have interval within the same plot. And so here we have CNC words, and then on our bottom panel, we have vowel recognition, again on percent correct performance. And now instead of shading and shape of symbol indicating whether they're in a default or place-based map, we have the results in the filled squares at the 1-month interval, and then the open circles for the results at the 6-month interval, and then lines connecting the performance for individual users. And again, we have absolute frequency to place mismatch at 1500 Hertz on this axis. And so plotting the data these way, what you can see is that listeners that have minimal amounts of mismatch tend to jump up and have good performance with the device early, and then small changes in speech recognition by that 6-month interval. Listeners that have minimal or some mismatch tend to have poorer performance at that 1-month interval, and then have larger changes in speech recognition by the 6-month interval, where they're within that range of our patients with no electric mismatch. So this is showing that they can acclimate to these mismatches within this 6-month period. However, our listeners with more electric mismatch or greater magnitudes of mismatch are having less of a growth in speech recognition performance and tend to have poorer performance overall, with this listener not experiencing an improvement between the 1 and the 6-month interval. Something you'll notice is that some listeners have a diagonal line, and what is happening there is with the default procedure, if your acoustic hearing changes, then you change your electric filters, because again, the goal is to provide the listener with the full speech spectrum and avoid gaps between the acoustic and the electric component. So if my hearing shifts, to make sure that I don't have a gap, I'll change my electric filters, and that's causing another shift in speech or in the frequency information relative to the cochlear place frequency. And it could be that this is making the listener repeatedly start over. So I'm starting to acclimate to these spectral shifts. Well, now you shifted me again, and I need to start this process over. And so that could be driving some of the changes that we're seeing with these individuals, these 3 that have had some changes in their filter frequency assignments. Okay, so now let's shift over to the ones that have normal to near normal hearing in the contralateral ear. So these are CI and EAS users, all with single side deafness or unilateral hearing loss. And these data were pulled from 2 samples. So the first sample was pulled from our clinical trial cohort. So in 2014, we started our clinical trial on cochlear implantation in cases of single side deafness in adults. And we had 20 adult cochlear implant recipients that participated in that and had data through the 12-month interval. We only had available postoperative CT scans for 18 of those, where we could go through and identify where those electric or where those contacts were, so that we could calculate electric frequency to place mismatch. All of our recipients in that clinical trial received the standard 31.5 millimeter electrode array, with the rationale being that it should minimize or have the least amount of intraoral mismatch with the contralateral ear. So all of our recipients received that. The second group is from the mapping study that I just described, where we are taking anyone who's received a Med-El device and is willing to participate, and we randomize them at initial activation to listen with either the default or a place-based map. And we have 11 or data currently from 11 adult CI or EAS users. And again, we have a range of 2 from the recipients of the 24 millimeter array, 1 with the 28 millimeter, and then 8 with the 31.5 millimeter. And the reason for this discrepancy in the sample is because since we saw such an excellent improvement in our clinical trial when we were using this long array, there is a preference for our team to use a long array in patients that are presenting with normal to near normal hearing in the contralateral ear. Again, with the place-based mapping procedure, we're using that postoperative CT scan so that we can calculate angular insertion depth and align the filters up to at least the 3000 Hertz place frequency. And for our EAS users, the same practice is applied as what was described before, where we are programming the acoustic component to NAL, NL1 targets. And these data are on a masked speech recognition task. So we have the listener seated in the center of a 11 speaker arc that's spanning 180 degrees. And we are presenting them with the AZ biosentences and the 10 talker masker, so what we're using clinically, but this is at a 0 dBSNR, so the speech and the mask are at the same intensity level. And the data are from 2 target to masker configurations. The first one is where the target speech and the masker are presented from the front speaker. And then the second is where the target is still from the front, but the masker is 90 degrees towards that normal hearing ear. And we are calculating performance as the spatial release from masking. So the benefit that a listener experiences when the masker is offset relative to the target. And so if we're using our binaural hearing cues, then as we move that masker further away from the target, we should have better performance than when the target and the masker are co-located. And these are those data that we have been reviewing. And so first, I want to call your attention that these are data at the 12-month post-activation interval. So all these listeners have had 12 months of listening experience for their CI or EAS device. On this axis, we have spatial release from masking. So a higher value indicates better performance or ability to benefit from the masker being offset relative to the target speech. And then on this axis, we have frequency to place mismatch at 1500 Hertz. So again, 0 indicates a match between the frequency information we're presenting and the cochlear place frequency. And then we can see further magnitudes of mismatch. Now, something to point out is in the previous patient population, I showed you out to 12 semitones, which is 1 octave of mismatch. In this case, the most that we have is 9. And that's interesting to consider because within this patient population, where the majority are receiving or recipients of the 31.5 millimeter array, we have what we would have considered minimal amounts of mismatch relative to what we see in other patient populations. The way that we have this plotted here is the filled circles are for the data for the participants from the clinical trial. And then the triangles and squares are indicating the individual performance for the listeners from the mapping study that we are conducting currently. So if it's filled, they're listening to a default map. If it's open, they're listening to a place-based map. This person is emphasized because he is an EAS user with a default map with electrode contacts that are identified to be within that region of functional acoustic hearing. So what we're seeing, and this was surprising to us, is that listeners with minimal amounts of electric mismatch are showing more benefit on this task than those that have greater amounts of mismatch. And this, again, is at the 12-month interval. So it could be that even these minimal, or what we used to consider to be minimal amounts of mismatch, are still negatively impacting binaural hearing performance after a year of listening experience. And so we think that this is important to be paying attention to when we are programming this patient population. So in summary of these, at least preliminary data, for monaural speech recognition of EAS users, we're seeing better early performance when electric mismatches are minimal. And then for binaural hearing in CI and EAS users with unilateral hearing loss or SSD, we think that electric mismatches are continuing to impact binaural hearing abilities even out to 12 months of listening experience. And this is something that physicians and audiologists should be paying more attention to. And we think that methods to minimize or eliminate electric mismatches may support early and long-term hearing abilities. So future directions, which you're probably already thinking. So yes, we are continuing to do this study. We're looking at long-term performance out to 12 months of listening experience with either the default or the place-based map. We also switch them to see if there's a benefit of one versus the other, and then what do they select at the completion of the study endpoint. Do they select the default or the place-based map? And we are also considering clinically feasible methods to eliminate electric or to limit electric on acoustic masking. So currently what we do if we identify contacts that are within that region of functional acoustic hearing is we turn the stimulation down, but that might not be enough. We don't know if that is the best way to approach minimizing electric on acoustic masking or peripheral masking. So those are two things that we're currently working on and continuing to investigate. But now with the FDA approval of Otoplan, where you can look to see or take in this preoperative image of the cochlea, is to use that to identify the cochlear duct length and then potentially use that information to select the electrode array. So is this patient better suited for a 31.5 or a 28 millimeter array, so that you are eliminating electric mismatch from the start. You're already close to cochlear place frequency just by the selection of the electrode array. So in summary, when we're thinking about imaging in the management of our CI recipients, traditional use, we have been using that to assess the electrode array placement, either intraoperatively or initially postoperatively, or in patients that have presented with issues that we think it might be due to electrode migration or some other issue that is occurring. Our current studies of CI and EAS users, we're seeing that they are experiencing better monaural and binaural hearing with these individualized maps that are based off of imaging. And for future directions, we think that the use of cochlear morphology, so if we know more about the cochlear morphology, that can be used in the selection of electrode array to potentially provide patients with better outcomes. With that, I'd like to thank you for your attention, and then also thank our funding sources, MED-EL Corporation and the NIDCD, for their support of this work. Thank you.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.